Good evening, everyone. Thank you so much for all the participants who are joining us. I can see our guest, Dr. Anil Jain, has also joined our call. Thank you so much, sir, for joining us. We'll just begin the session in a minute. Just waiting on for some more participants to join in, and we'll start off with the webinar in a bit. Thank you so much again for the ones who've been joining us. All right. Okay, thank you so much again, and officially welcome to the first webinar of Decode the Specialty, organized by Medical Students Association of India as a part of MedFest 2020. Decode, to just introduce the entire concept to you all, Decode a Specialty is a guest lecture series which which the medical it is a kind request to everybody to please unmute your mics, because to avoid any sort of disturbance, so that we can smoothly go in the entire webinar. Thank you so much. And as I was saying, that Decode a Specialty is one of the events organized by the Medical Students Association of India for all the medical students out there to clarify their doubts, to know more about the various specialties out there, and to clarify any of the questions or the doubts they might have. For the same, we have eminent specialists from all across the country to help us and guide us in their best capacity. To introduce myself, my name is Molly Mehta, and I'm currently working as the Vice President for External Affairs at the Medical Students Association of India. Without any further ado, I would love to introduce our speaker and our guest for today, Dr. Anil Jain, who is one of the leading cardiovascular and thoracic surgeons of India and is also the founder of Heart Care Associates India. He's one of the first surgeons to adopt beating heart, the surgery for CABG, and is also responsible for starting and developing and promoting the surgery for heart failure, which again is one in many of his firsts. In a span of 22 years, he, along with his team of 50 to 20 super talented doctors, have performed more than 40,000 surgeries and have saved innumerable lives with their care. It is an honor for us to have you with us, sir. We'll be more than grateful for you to take the floor and take the session ahead. Just a minute.
Good evening.
Hello.
Molly, can you see me? Can you hear me?
Yes, absolutely. Very clear.
Just give me 1 second. I need to set the light a little bit.
No worries at all.
I think, yeah, that is okay. Now it's fine. Can you see me okay?
Yes, perfect.
Yeah, how are you, Molly?
I'm good. Thank you so much again for joining us.
Congratulations for organizing such a lovely event. I'm sure it will inspire a lot of people to do things differently. I don't know how many people like surgery, but surgery, I think, is the epicenter of medicine. I know medicine, I don't want to undermine medicine, but surgery is a different ball game. Maybe because I'm a surgeon, I think so, but it is a totally different ball game. Thank you.
Absolutely.
You want us to start straight away?
Yes. So
wait for some time.
Yes. So just to give everybody a gist again, the topic which we'll be covering today with Dr. Anil Jain is the past, present, and future of cardiac surgery. Cardiac surgery, a lot of us are very attracted to the field of cardiac surgery, but it is very important for us to know more about it, to exactly know what it entails for us and contains for us to get into the field. And these are the doubts which we'll be clarifying in today's webinar. So we can very well go ahead with the presentation and with starting off with the session for today.
Thank you. We'll start the presentation. Jenny. light got switched off, the fan switched off. One of the two. No, the first and the second one. Switch off one, switch off. Okay, Mauli, can you see the presentation? Is it seen to everybody? Okay, do you think I can start? You are muted. Can
Yeah.
you?
Yeah, I'm so sorry again. We can see your screen, sir. And just a kind request to all the participants to kindly keep your mics on mute so that we can avoid any sort of unnecessary disturbance in the entire session. Please feel free to drop any of the questions, any doubts you would want to ask in the chat box, and by the end or at the end of the session, we'll be addressing the questions. But please feel free to drop down any questions you might have, and yeah, we can absolutely proceed with the presentation, sir.
Can you see the presentation on the screen, Mauli?
Yes, yes,
Is
yes,
it okay?
yes.
Okay, good. Let's go. Good evening, everyone. All the students, all the doctors, and everybody that are online for the evening session. Today, we are going to talk on cardiac surgery, the past, the present, and the future. Cardiac surgery always has been a matter of awe and respect for all the medical professionals, because I think heart is the center of the entire being. We say the soul resides in the heart. We talk our soul, our soul. So even when I went to the operating theater the first time and I saw a heart, I was totally mystified. I didn't know in which chamber of the heart the soul resides. Well, I spent maybe 30, 40 years in cardiac surgery, but still I've had this search for the soul. I've opened all the chambers, not able to find it right now. Cardiac surgery itself has its humble beginning in the World War. When the World Wars began, that time there were people, soldiers who used to get shrapnel injury into the heart, and surgeons used to remove shrapnel. And it was believed that will be the limit that a cardiac surgeon could ever do. Just take out bullets or take out pieces of shells from the heart and hope the person lives. It was thought that this is going to be beyond mankind's reach and approach. So that is where it began. However, the very first surgery aimed at treating some congenital defect or some cardiac defect was performed in 1944 by Sir Blalock Tassig. It was called the BT shunt. And that was a shunt done from the subclavian artery to the pulmonary artery to help reduce the cyanosis in a tetralogy of Fallot. This operation was successful, and it marked the beginning of some cure of cardiac ailments by cardiac surgery or some form of vascular surgery. It was not a cardiac surgery actually, it was more a vascular operation for a cardiac disease, but that was the very first operation ever done. In 1953, Dr. Gibbon, he invented, as we call, the heart-lung machine, and heart-lung machine is the basis of all major cardiac surgeries done. Mauli, can you hear me well? Yeah. So it is the basis, it is the foundation of cardiac surgery today. And the first cardiac surgery done on this machine was done in 1953 by Dr. John Gibbon. It is amazing to imagine why this man thought of inventing such a device, such a machine. As an intern, he was going around in the wards, and suddenly a person crashed in the ward, and it was found that he had pulmonary embolism. He struggled hard trying to revive the patient. But as you know, if there's an arrest due to pulmonary embolism, without taking the clot, the person is not going to survive. And then Dr. Gibbon thought that if we can find some way to bypass the heart and keep it on a machine for some time, then maybe we can go in, operate, and remove the clot and then help revive the patient. So it is for that particular ailment that the heart-lung machine was invented by Dr. Gibbon. However, today still, surgical treatment of pulmonary embolism is very difficult and it still eludes us. But a lot more has been done by these machines. The only sad thing was Dr. Gibbon used it to close an ASD for the first time in 1953. But that was his only successful operation, and the following 6 patients died, after which he gave up on this particular heart-lung machine. This is how the heart-lung machine used to look, and the first surgery being done by Dr. John Gibbon. So once people believed the heart-lung machine would not work, so they thought of doing cardiac surgery with hypothermia, and this had its basis again in the World War. Soldiers would be, soldiers would were around sinking in the cold Atlantic Ocean, and they would have cardiac arrest. And when they were revived or rewarmed after some time, they would still be alive and neurologically all right. So from there, this idea of cold hypothermia came, and patients were cooled down to temperatures such as 22, 23 degrees. Heart was arrested, cardiac surgery was performed, and once again the patient was rewarmed, and that way some surgeries were performed on the heart. So it was called cold hypothermia. It was then that Dr. C. Walton Lillyhigh, he is considered the father of modern cardiac surgery. And he was there from 1918 to 1999. And he is the man who's said to be father who, really changed the way we think about cardiac surgery, the way we do cardiac surgery, and like the father, he mentored cardiac surgery to what it is today. And he did one of the most controversial operations in the world. And he did, there were children who had congenital heart disease and their mother would be there. So you would use the mother like the heart-lung machine, and I'll come back to it, where the mother would support the circulation while the child was operated. So that was the first time something was done in the world. And if something would go wrong, both the people would die, the mother and the child. But this man performed 22 surgeries, and all the patients did well. So it was controlled cross circulation. As you can see, one side is the baby, one side is the mother, and the baby's heart was supported by the mother's circulation. This was an amazing operation. 22 children were operated, congenital heart diseases, and all the 22 survived. But yet, that could not be the answer to doing real cardiac surgery. So later on, he further worked very hard on the heart-lung machine, and he devised the modern cardiac surgery machines or heart-lung machines as we know. Weinberg did an operation for coronary artery disease, and it was a very different type of operation. He would take out the left internal mammary from the thorax and implant it into the muscle of the heart, and this was called Weinberg operation. He did many such surgeries, and quite a few people benefited, but still, this was not the real answer to coronary artery disease. The one operation that really worked and that really saved a lot of lives was the closed mitral commissurotomy. And this was devised by Dr. Tubb. This is called Dr. Tubb's dilator. And he devised this sort of a dilator. And this operation was done on beating heart. A Tubbs dilator was introduced through the apex of the heart, would cross the apex of the left ventricle, it would cross the mitral valve, and the finger was introduced from the left atrium. And all this was done through a left thoracotomy and with the patient, with a beating heart. The heart was maintaining circulation. And this Tubbs dilator was passed across the mitral valve and opened, and the valve dilated, and thereby treating mitral stenosis. So the idea of doing mitral stenosis treatment was to increase the mitral valve area, and this dilator did it. Thousands and thousands of these operations were done to address mitral stenosis. And honestly, till date, there are many patient lives who have benefited from this one surgery. I think this was one of the finest operations done worldwide. So now coming to the present, that is the history. And like I said, Tubbs closed mitral is the latest, the most recent history of cardiac surgery. After that, it all came to open heart surgery, and as we know, as the modern cardiac surgery as we see it. For benefit, I've divided cardiac surgery into various areas: the coronary artery disease, the valvular heart disease, surgery for heart failure, and minimally invasive cardiac surgery. Today, I'm not going to touch congenital heart surgery because that's an entire separate field by itself, and we cannot cover so much in an hour's time. But that also has done leaps and bounds of growth. Now, what is coronary artery disease? I'm sure all of you know coronary artery disease is where various lesions come in the coronary arteries, like you see this block. And what do we do after the lesions come? We try and bypass it. We put vein grafts or mammary artery grafts or the radial artery graft and bypass the block. So that is coronary artery bypass surgery as we perform it now. And this is a very standard operation for patients suffering from coronary artery disease. If they cannot have angioplasty, if they are not okay with medicine and still they have unstable angina, then we put bypasses. So basically it's a bypass operation because we are bypassing the block. We are not touching the block. And the conduits, there is a conduit, can be a vein, a radial or a mammary artery, it bypasses the block. So that's called coronary artery bypass surgery as we know it, and it's a very popular operation. In fact, some years ago I had read that this operation was a more frequently operation performed than even cesarean sections. And this is one of the most successful operations with risk and reward. So the best risk reward is there for coronary artery bypass surgery. What are the common conduits used to perform this operation? It's a vein, it can be a radial artery, it can be mammary artery graft, and it can be performed either on the beating heart or on the heart-lung machine. So this is how it is. There would be a lesion here. There will be some block here. We take out the internal mammary artery from the thorax and we put it distal to the block. We can take out a vein graft. There's a lesion here and we can attach it distally to the coronary artery. And this operation has also become better over years because we have got excellent magnifying loops that we wear. We have got excellent lights. Suture materials are excellent. Coronary arteries can be something like 1.5 to 2 millimeters. Just try to mark 1.5, 2 millimeters at home in a scale. That's the diameter of the artery. And we open the artery, we anastomose a graft, and we hope it works. And well, these graft work for nearly a period of 20 years. It really does well, SI. So this is a very successful operation, and conduits are used to bypass the block. Here, this is a total arterial operation where the lima, rima are put as a Y graft on the heart and anastomosed to the distal target artery. And this is how a radial artery can be placed distal to a lesion. And this is exactly how it looks. If you go on the operating table, it will look like this, and I'll show you a few pictures. Now, what is the difference? Why do we have these different type of grafts? Vein grafts, they're good, but they have a limited patency. Only advantage is patients have a lot of veins. Both lower limb, great saphenous veins are harvested and they're used for grafting. A saphenous vein has a 60% patency at 10 years, but later after that, it must slowly atherosclerose and block. But why vein graft? Because they're plenty, they're easy to use, but they are not accustomed to arterial pressure. Hence, they are prone to atherosclerosis and their long-term patency is not good. So vein grafts are used for bypass, but they may not be the best option. This is how a vein graft looks. It's harvested from the leg, the branches are tied and used as a conduit, like from aorta to beyond the block on the coronary artery. The radial artery is another conduit that was advocated by Dr. Carpentier. And the only problem was in radial artery grafts is sometimes these used to go into spasm. So once calcium channel blockers, I'm sure all of you know about diltiazem, amlodipine and other things. Once these things were discovered, we could, use these arterial grafts more frequently for coronary artery bypass surgery. And this is how, from anatomy, all of you must remember radial arteries in the forearm. And this is how a harvested radial artery looks. It's here and it's here. So a harvested radial artery looks, and it is used as a conduit for coronary bypass surgery. This is, if you do an angiogram later on, you can see how the radial artery, this is the coronary artery, and this is the conduit. It's coming from top to the conduit distally wherever it needs to be grafted. So these grafts are good because the radial arteries, they last longer. I'm sure all of you remember the internal mammary artery that lies on the inner side, parasternum, along the costal cartilages. There is a mammary artery. It's called the internal mammary artery. And this artery is like a gold standard for bypass surgery. This is dissected from the chest wall and some papaverine is sprayed and then it's ready to use. This artery is very good for bypass surgery because it does not develop atherosclerosis. It is immune to atherosclerosis. It is immune to atherosclerosis. It does not go into spasm because there is very little muscular layer. And this artery also secretes a lot of nitric oxide, which helps improve the patency of the distal artery and reduce development of disease distally. So we have these three conduits, surgeons harvest them and use them for bypass. So we can take out both the arteries, and with two arteries, we can do all the bypasses in the heart. So we don't need a vein, we don't need a radial. This is what one internal mammary would look like. This is how the other internal mammary looks like. And we do a Y graft. This is lima, this is rima. We have done a joint here. They're anastomosed, and these are then grafted all over the heart. Like this is what a heart looks like. And I'm sure all of you say, I love you to one another. And I don't know from which corner of the heart you people say, I love you. Well, it's from the bottom of the heart. So this is, I think, the bottom. So this is what a heart looks like. It's just a muscular sac. There isn't much else, but this works for over maybe 70 years, 80 years, 90 years, how long you live. And it's amazing muscle. I'm sure you all remember the physiology. This muscle can work tirelessly for 70 years without any rest. But if lesions develop, we have to put grafts. So this is how an internal mammary artery comes. There is one graft done to the diagonal, one done here to the LAD, and this goes to the rest of the arteries behind the heart, the marginals and the PDA. This is the aorta, this is the left ventricle, this is the right ventricle. This is how the heart looks. Well, so what are the patency rates? The best patency rates are, of course, for mammary. But radial artery, as you can see in this graph, various studies have been done. Okay, what should be used? So radial artery is definitely better than a vein graft for even long-term survival and event-free survival and rehospitalization or acute MIs. So they are better grafts than that. The mammary artery graft, unfortunately, the blue is mammary, red is the vein. The blue is the mammary, and it shows that the 15-year patency of a mammary graft is 82 years, and freedom from cardiac death, freedom from cardiac death or freedom from all-cause mortality is more than 90% if a mammary conduit is used. So if anyone known to you has to have a bypass surgery, be sure that he should get at least one mammary artery, because the long-term patency of mammary artery grafts is better than anything else. So this is how the cardiac event-free survival and death is much less if mammary artery conduits are used. Now, when you want to put these grafts, how can you put them? You can put them on the pump or you can put off pump. Now, what is on pump and off pump? See, routine surgeries are done on machines called the heart lung machine, where we drain the blood from the venous system. And it's like the venous system will drain the blood, take it into something called an oxygenator, and pump it back into the aorta. So the heart lung machine bypasses both the heart and the lungs. It helps to keep circulation going, which is what we do. You saw Gibbon's machine and look at the modern machines. They are so sleek and such wonderful machines and very efficient. And as I say now, there is no risk of putting a patient on heart lung machine. The quality of the oxygenators that oxygenate the blood, the pumps, the technology associated with that is fantastic. And if you come to cardiac theater, it looks like a cockpit. It is so much gadgetry and such beautiful gadgetry. It's a pleasure to work with such machines. And well, we work with them day and night, and heart lung machines are very good. So if you do on the heart lung machine, that's called the heart lung machine, and you put the patient in cardiac bypass, and that's one way. Now, all coronary arteries run on the surface of the heart. And if the patient is okay, then you can do something called a beating heart surgery. So we have devices like this called Octopus. They are stabilizers. We fix them on the heart. This is a coronary artery, and we can do it without putting the patient on the heart lung machine. So we can do something called beating heart surgery. As you will see here, okay, this is the Octopus. That's the hand surgeon. He will put the Octopus on the heart, on the coronary artery, and that uses a simple suction device. So the entire heart is beating, the coronary artery is seen in the middle, and it's well stabilized. So all we need to do is to make anastomosis. So we do not need to stop the heart. So what is the advantage of beating heart surgery? It is more physiological. Patient is not put on a heart lung machine. The oxygenator is not being used to oxygenate the blood. Hence, the patient gets what we say a less invasive physiologically operation. He just gets an operation where the heart is still beating, and on this beating heart condition, a graft is placed. So this is called off-pump surgery. And show you how we do a little bit of the anastomosis. Like you see, this is the artery that has been opened up, and here is the target vessel, and this is the mammary artery. And this over time is anastomosed. And here the artery is anastomosed on the beating heart. So this is called off-pump cardiac surgery. This is good for people who have bad lungs, where you don't get, pump lungs later on, don't have renal failure. And sometimes the aorta is very atherosclerotic, and you cannot put such patients on heart lung machine. So for them, we can use such off-pump coronary surgery. Now coming to valvular heart disease. See, valvular heart disease was even preceded coronary artery disease, but answers to this disease have been more difficult. And over past 50 years, engineers, biomedical engineers, and scientists have worked to try to develop the most perfect valve. But still, we do not have the perfect valve for replacement in case a patient needs a replacement. Now, patients can have mitral stenosis or mitral regurgitation and valves that do not allow proper flow of blood. So we need to replace these valves. So in valvular heart disease, if the valve is too bad, you need to replace a valve, and there are various processes that can be used. However, if we do not wish to replace the valve, then we try and repair the valve, and repairs are better than replacement. And third is, sometimes patients have atrial fibrillation. I'm sure all of you know about atrial fibrillation. It's a pretty common disease. So if a patient has atrial fibrillation, you need to try to, do something to get the rhythm back to normal. So what are the valves available? We've got 3-4 types of valves. One is the mechanical valve, other is tissue valve, and third is valve repair. I'm honest and I tell you, it's an awesome experience to open somebody's heart, go into the left atrium, cut out the old valve and try and put a new valve, again fill up the heart with blood, come off the heart lung machine, and there the patient is okay, this valve is fine. You know, I don't want to say that, it doesn't look to say that, nice to say that, but you know, sometimes cardiac surgeons start feeling we are God. Why? Because you can stop the heart and you can start the heart, and not many people in the world can do that. So to do a valve replacement surgery, you need heart lung machine. Everybody has to go off the heart lung, always stand still heart, open the heart, and then replace the valve. The valves cannot be replaced surgically without heart lung machine. So we have three options. We can either replace the valve, we can put it a mechanical or a tissue valve, or we can try and repair valves. So let's look into it. Now, mechanical valves are excellent. They are made of pyrolytic carbon. A lot of engineering has gone into it. Okay, getting your update ready. What is this? Let's go. Restart later. Just 1 minute. Now not karna, restart later. So we can, mechanical valves have developed very well over the past so many years, and now valves are so well done structurally that they can last for the patient's entire lifetime. But the only problem is these need anticoagulation, and anticoagulation is with acetone, which is not easy. If too much anticoagulation is done, people can bleed. If too little anticoagulation is done, then the patient's valve can clot. So mechanical valves are good for valve replacement. They can last the patient's lifetime, but they have this problem that they can either get thrombosed or they can be bleeding. So that is one problem with these valves, but yet these valves are the necessity, and in all young patients who are less than 60 years, we use mechanical valves, and I'll come to that answer also why. So mechanical valves is a good answer. Where valve cannot be repaired and the patient is young, we use mechanical valve. The other thing we have is bioprosthetic valves. Bioprosthetic valves are biological valves. They can come from the pig as such, or they can be made from cow pericardium. So these are what the various valves look like. There are various types of valves, and a lot of companies make a lot of valves with a lot of tissue treatment. So what is the problem with the bioprosthetic valve? The problem is if the valve is, it's a tissue, it's a sort of animal tissue. So over time, inside the patient's body, the valves can degenerate, and these valves, once they degenerate, again they need to be replaced. So that is the problem with tissue valves. Whereas mechanical valves can last a lifetime. But the advantage is that these do not need anticoagulation, and that is the best part. Because they degenerate, they're okay for people above 60 years of age, and this is where they're classically addressed to. Over 60 years of age, bioprosthetic valves are used, and they do not degenerate. They degenerate. That's the limitation. Hence, good for old elderly people. But now newer treatments have been given to these valves, more modern anti-calcific treatment, and people believe that these valves would even last 20, 30 years. So in people who have less than 20, 30 years of expectation, they can easily be used. Even longer can be used because in future, new technologies are coming in where these biological valves will be replaced percutaneously using valve-in-valve technique. So these are biological valves, they don't need anticoagulation, but they have a problem of degeneration. So they are very popular. They are in fact more in demand than mechanical valves, and patients feel better. So both the valves have their pros and cons. Some have the tissue valve, the mechanical valve has the risk of bleeding. The tissue valve has the risk of reoperation. But so see, both these have a problem, either bleeding or reoperation. So how can we reduce these problems? So the only way to come around this problem is try and repair the valve. So if somebody has got a valve that can be repaired, then you don't need to have the problem of anticoagulation with mechanical valve, and you don't have the problem of degeneration of tissue valve. So can valves be repaired? Yes, valves can be repaired. So if there is a patient with mitral regurgitation or mitral valvular disease, if you repair the valve, get his rhythm back to normal, you will be able to neutralize the disease. You will be able to cure the patient for lifetime. And that is the aim of a doctor, to try to cure the patient. So repair is the most superior answer, but not everybody can have a repair. So wherever the valve is suitable, mitral valve, the valve should be repaired. Repairs are popular for mitral valve. So what are the advantages of mitral valve repair? It preserves the native valve. It avoids the problem of prosthetic valve. The hemodynamics, the LV functions are better preserved with the repair, and the long-term survival, because there is neither degeneration or there is neither need of anticoagulation. The long-term survival is also better with repair. So wherever possible, repair of the valve should be done, and they should not be replaced. Popularly, they're done in mitral valve, but we also try to do them with aortic valve wherever possible. She's one of the first ladies in the world who had a mitral valve repair in 1923 for some valvular heart disease. It is Alan Carpentier who basically, developed modern techniques as we identify them today for mitral valve repair. He said that he classified the valve according to the disease and gave us various, solutions of how to repair the valve. And all the repairs now, most of the time, they are called Carpentier repairs in honor of this man, French man, Alan Carpentier, who devised repairs. Amazing man, honestly, very few people live lives like him. Amazing surgeon who changed the life of valvular heart disease patients. So which valves can be repaired? Not all valves can be repaired. Most frequently, degenerative valves can be repaired like Barlow's, mitral valve prolapse, degenerative rupture of chordae. Then the ischemic valves can be repaired. Ischemic cardiomyopathy valves can be repaired. Sometimes endocarditis can be repaired, and very few rheumatic carditis valves can be repaired. Why? What is the problem with rheumatic carditis? Rheumatic carditis basically affects the primary tissue. The primary tissue of the valve gets damaged. Hence, you do not have adequate substance to repair the valve with. So more frequently than not, we repair the other valves, and less frequently we repair rheumatic valves. Yeah, Jain, tell me. I can. You take it from here. Just sorry. So we'll talk about mitral valve repair. How are the repairs? And just a brief example I will give you. Repairs are like, for example, if there's mitral valve prolapse, the posterior leaflet chordaes are damaged. We go in, we resect a little bit of that chordae, stitch the valve together, and put a ring to stabilize it. Amazing operation. I did one just the other day for a 71-year-old gentleman. So they are very rewarding. You feel that you've not replaced the valve and patient has his own valve and he will have better long-term result. So these are amazing operations and it is wonderful to do them. It is very satisfying. So this is called quadrangular resection with annuloplasty. In rheumatic patients, we go in, there's commissural fusion. We open the commissures, we can split the papillary muscle, we can split the chordae, and we can also peel the valves and make it better. So like that. So these are excellent options for repair and they should definitely be used for patients where they can in rheumatic heart disease. Sometimes patients have endocarditis. There are such small perforations in the valves and we can take pieces of pericardium and repair them. In endocarditis, these solutions are vital because what happens if you repair an endocarditis valve, you don't have to worry about repeat endocarditis or, prosthetic valve endocarditis is a very bad disease. So you don't have to worry about prosthetic valve endocarditis. So, like I said, valves are repaired by, we can do quadrangular resection and stuff like that. And all valves need to be stabilized with something called an annuloplasty ring. And that is what keeps the valve together. So, a lot of people have looked into survival between valve repair and replacement. As you can see, the repair survival is always better than replacement. And if it's a good repair, then the survival of the patient may be equal to age-matched patient in the population. So that's a very nice, person feels so good. It's a young girl and she gets repaired. She can have pregnancy. If it's a young man, he can have normal sports, normal occupation. So trying to repair the valve is a better solution than trying to replace the valve, but not all valves can be repaired also. So like you can see, all the studies have shown age-matched survival is always better with repair than a replacement. Aortic valve repair, up till now, there was not much popularity on aortic valve repair, but recently many surgeons like Professor Schaefer from Hamburg and some surgeons from Belgium have popularized repair in aortic valve. Aortic valve is a very complex valve because aortic repair is very difficult because it's a very complex valve. It has got, as we call, the ventricular aortic annulus. It has got the sinotubular junction, and it has got 3 leaflets. This is a very complex thing to try and repair. And still surgeons have worked out a lot of techniques and many surgeons, even we are one unit that does regular aortic valve repair. This is a Schaefer's caliper that helps us do these repairs. So what you can do, sometimes the leaflets are damaged, so leaflets are prolapsing. We do free margin plication. We can plicate the leaflets like this. We can do resuspension. If there's a simple prolapse of the leaflet, we go in, take a suture, and we resuspend the leaflet. Sometimes we can do something called triangular resection, like quadrangular resection for mitral. We can do a quadrangular resection for the leaflet. And if the leaflet is very badly damaged, we can do pericardial extensions. So these are complex repairs. But to tell you children or students, it's important that we understand that such treatments are offered by surgeons, and these are good for long-term survival of patients. And this is how science has advanced from replacement to repair. And repair has been very difficult. But yes, people have got good techniques for repair, and they have become very popular. Now, coming to the rhythm part, I've talked to you about replacement using mechanical, replacement using tissue valves, and I've talked to you repair. Rhythm needs to be restored. Why? See, a sinus rhythm is always better than atrial fibrillation. In atrial fibrillation, a 25% of cardiac output that comes because of the atrial kick is lost. Not only that, if the person has got atrial fibrillation, then they have got feeling of palpitation, they get embolism, and and over time, RV dysfunction also develops. So atrial fibrillation is a bad disease, and it's a big nuisance to both doctors and the patients. You can go in, do a good mitral valve repair, but if the patient has atrial fibrillation, again, you need to anticoagulate, so you lose the advantage. And when can you do atrial fibrillation correction? Only at the time of primary surgery. Something like 40% patients going for mitral procedures have AF, something like 10 to 15% patients having valvular aortic valve surgeries have AF, and 10% of coronary bypass patients also have AF. So if you're going in for a primary surgery, that is the best opportunity to treat AF. Why? I'll tell you that also. Now, if someone has AF, the stroke risk goes up by 65 to 126%. The mortality in age-matched population will be more, like 50 to 90% if they have got AF, and hospital cost of treatment also go up. So AF is a predictor for stroke, mortality, and increased hospitalization, and that is truly bad. So what can you do? So once the heart is open, we go in and we get something called radio frequency cauteries, and we go in and make certain ablation pathways on the wall of the left atrium and the right atrium, and thereby we can, bring back the patient back to sinus rhythm. Imagine an atrial fibrillation, imagine a sinus rhythm. They are not comparable. Atrial fibrillation is a bad disease, and sinus rhythm is fantastic. And using this technique, we can get a 60 to 70% conversion to sinus. So what we do open the right atrium or the left atrium, and we make such lines using this pencil. We go back and forth and create lines of ablation, and that causes transmural injury of the wall and leads to interruption of atrial fibrillation pathways. So this is how we can correct atrial fibrillation also. So cardiac surgery truly is an amazing branch, and you can do wonderful type of surgeries and cure patients of dreadful things such as atrial fibrillation too. So that was unipolar, using just unipolar cauteries. Sometimes to be more effective, people also perform bipolar, or use these clamps and we
Like इसलिए
clamp on
बंद
the
नहीं कर
pulmonary
रही हूँ, अंदर वहाँ पे
arteries
पावर रखी हुई है फिर।
and help interrupt the pathways around the pulmonary veins. So these clamps are used, and atrial fibrillation can be corrected using them too. So there are many things done. I won't go into the nitty-gritty of how these operations are performed, but they are complex surgeries and they are wonderful. It's even good to do them as a surgeon. You enjoy doing such surgeries. So this is something that we do. We use these clamps, apply them on the atrial appendage, and that also helps to cure these arrhythmias. So coming to one of the last parts of my talk is surgery for ischemic heart failure. See, heart attacks are common, valvular diseases are common, dilated cardiomyopathies are common. So what is the final treatment for all this? What's the time? We have time. So what is the treatment for these diseases? And let me tell you, nothing as bad as heart failure. Imagine having to go being breathless throughout the day, keeping on going to the hospital for an injection of Lasix, taking diuretics all the time, having palpitations, not being able to do your daily routine like going to a toilet or walking around your garden. So it's pretty pathetic. So is there a treatment for heart failure? Yeah, there are some things that can be done for heart failure. One of them is called surgical ventricular restoration, and other common cause is mitral regurgitation and treatment of mitral regurgitation too. Now, I don't know how many of you remember the physiology of the heart, but this is the normal shape of the heart. The heart, when it contracts normally from the apex towards the base, it is a particular directed vector towards the aortic valve that ejects all the blood out of the heart. When there is a heart attack or valvular heart disease or anything, when the heart starts to fail, the first thing happens is the heart changes its shape from an elliptical shape to a football shape, round shape. And then when this heart is contracting, it contracts around the football, around the center of the heart, and does not vector blood to go out of the heart. Hence, the contractility or effective ejection of the heart comes down. So this is what a scar would look on the heart. So what do? We go in, we open the scar, and we change the shape and make it elliptical again. Let me show you a video on that. It's just something that will tell you, okay, what is the avenues, what are the things cardiac surgeons do, and how far we can go to treat cardiac ailments. So this is what a person gets a heart attack, and this tissue becomes a scar or aneurysmal tissue. And as you can see, this aneurysm will become a dyskinetic area on the heart, which does not allow blood to go from the heart. This is a dyskinetic segment. So we go in, open the left ventricle, we put a sizer inside the ventricle, and over that we close the heart again. And we remove the sizer, of course, before we close the heart. And we restore the heart back to its normal size and shape. And that's why it's called ventricular restoration surgery. And this makes all the difference between being breathless, being normal. We put a mannequin like this inside the heart over which we shape the heart. So this is how it is. The scar tissue, sizer, done. So it's normal. So this is an example. Heart was like this, badly shaped. We take out the stuff, put the sizer into it. Over that, we close the heart. And this patient was from Mahua, and he's still alive 10 years post surgery, doing very well. So this is an option to transplant. Everybody cannot get a transplant. Everybody cannot get an LV assist device. So as surgeons, you can go in and correct these things. Sometimes patients get heart attacks and their myocardium, the posterior area of the myocardium gets damaged, and the papillary muscle is pulled down, and that causes a valve to leak. So that increases the heart failure because there is a leaky valve. Any leaky valve can give heart failure. So we as surgeons can go in and do ring reductions, put rings on the mitral annulus and bring the annulus back together and control the mitral regurgitation, thereby treat the person of heart failure. So these are some examples of how heart failure can be corrected. See, even repairing a mitral valve, replacing a mitral valve, replacing an aortic valve, doing coronary bypass surgery, they also cure heart failure because coronary artery disease, valvular heart disease, or congenital heart disease also lead to congestive cardiac failure. The good thing about cardiac surgery is that it is, the results make always, the patient is always better at the end of the day. I'm not saying cancer is not required or bad, but cancer surgery, for example, if somebody has a CA breast, you end up removing the breast. So there is deformation. There's something that's done that doesn't make the person as whole or complete as the person was. But cardiac surgery will really go in, correct the defect, and people enjoy years of happy life after that. So cardiac surgery is something where you really is, a surgery with outcome. It's amazing. It's fantastic. So one of the problem with cardiac surgery is the big cuts. People don't like big cuts. Hence, we have now come to mid-cap surgery or small incision surgeries or lesser invasive surgery. And the advantage is we don't open the sternum. There'll be less bleeding, less scar, and people feel better. They're young girls who need a valve replacement or an ASD or something like that. And if you put a mid-sternotomy incision, she would feel very unhappy about it in the rest of her life. She has to live with the scar throughout her life. So we come to minimally invasive surgery. How are these done? For example, if a bypass surgery has to be done, we put a small incision just below the nipple and we go in. This is the size of the incision. We put special retractors, and through that we can see this is the left anterior descending artery, the one that you can see there. And on that we have put a graft. This is the artery. This is a stabilizer like we just showed you. And with that, we can do a coronary artery bypass surgery. And this is how the person looks. So this is how we put the stabilizers. The heart is beating, and in that will be, with this is how the artery is opened. And on this, the graft is, done. So minimally invasive surgery has its advantages, but its limitations. It can be done if one or two bypasses are required. You cannot do it if it's very bad disease, the heart is too big, or the patient is unstable. So wherever possible, as surgeons, we try and use a minimal access approach to treat our patients. Coming to, aortic valve surgery. Sometimes you have aortic valve disease. This is how a sternum retractor is put in the right second intercostal space, and we do aortic valve replacement. This is aortic valve minimally invasive. And this is what the scar looks of an AVR after minimally invasive surgery, whereas a sternotomy scar would have been a vertical scar. So we have smaller scars. Then mitral valve surgery, where do we put the incision? For ASDs and mitral valve replacements, we do submammary incisions, because if there's a young girl and we do something like this, then the scar is not seen for the rest of the life. Good for young boys also. It's not that only young girls need cosmesis. Anybody young who wants a lesser invasive surgery can have it. The only thing is this is more complex, difficult surgeries, and we use such instruments, long-handed instruments, to do minimally invasive surgery. This is how the incision looks. You use scopes and you do these surgeries using some mammary incisions, which are more acceptable to young girls and younger population than a sternal incision. So this is how we can see using a scope, and the scope has been placed. The heart is beating. Now the patient is on heart-lung machine, so the right atrium is totally empty. And then we open the left atrium. This is where the left atrium is. It will be opened, and we can go in and replace the valve. So we can do replacement, we can do repair. But however, if it's a smaller framed patient, it is more easy. And here you can see the mitral valve here, which needs to be replaced. So this is a mitral valve surgery using minimally invasive techniques. So these are cosmetically good. They avoid sternal sparing, they are sternal sparing and the less chance of infection and faster recovery. However, they are more expensive. Not everybody can do it, and they require more specialized equipment. So we also have surgeries for aortic aneurysms. Many times patients have dissection of aorta. We can go in and we can replace it using a Bentall operation. Sometimes they have got aneurysms in the arch of the aorta. So nowadays we get stent grafts. We can percutaneously place these grafts through the femoral artery into the arch of the aorta or descending aorta. Wherever we want, we get some stent grafts and we can place them. So there's a lot of aneurysm surgeries also that cardiac surgeons do. This is, for example, an abdominal aortic aneurysm, and it is replaced by a bifurcation aortic graft, like this in the place of the aortic aneurysm. So this can be done open, this can be done percutaneously also. So this is a very huge approach, and cardiac surgery definitely is a very rewarding operation. And it's amazing how a person goes, there are patients we take in massaging, and you go in, put them on the heart-lung machine, put a few bypasses or replace the valve, and post-operatively you'll have the patient nice and awake. So what does the future hold? Many times people think if angioplasty is done nowadays, or there are cardiologists who are doing a lot of work on the heart, the surgeons are going to become free. They won't have any work. And is there a future for cardiac surgery? Well, the more the angioplasty is done, the more cardiac surgery is being done, because a cardiologist to find a patient for angioplasty will keep searching patients of coronary artery disease throughout the day. And for every 2 or 3 angioplasties they do find 2 or 3 cardiac surgery patients. And not all. In fact, Indian population is badly diabetic, badly diseased, and a lot of people need coronary bypass surgery, which cannot be corrected using stents. So the future is still very, very bright. And what more are we looking in cardiac surgery? We are looking at robotic cardiac surgery, stem cell therapy, genetic engineering, mechanical hearts, and hybrid procedures. So this is something that may come in the future. Robotics, where surgeon is in one room and the patient is in another room, and using robots will be able to do this type of surgeries. And robots are amazing. Seeing is believing. I've worked on them for some time. They're very expensive. We can't afford them in India that easily for our patients, but they're amazing. And I'm very sure with time to come, robotic surgery will become more popular in cardiac surgery, because it is less invasive, easier to perform, better view, and more dexterity for the surgeon. So this is something that next generation, when they do cardiac surgery, they may get to use, which I did not get to use. There is transaortic valve replacement, where you go through the transarterial. From the femoral artery, you get valves that are mounted on such catheters, and you can go percutaneously and replace these valves using percutaneous technology. Only just a few minutes, last few slides.
Yes.
So this is what it is like, there is this heart that's beating, and over a balloon, a valve is passed. This is an expensive therapy right now, but I'm sure with time, more of this will happen, and the next generation of cardiac surgeons or people who come in will see more and more of this. The other thing that is stem cell engineering. We will be getting stem cells. It is the holy grail. If we know how to use stem cells in the heart, we'll be able to inject it all over the heart and help revive dead myocardium following either post-infarction or purely dilated cardiomyopathy. So stealth stem cell therapy is also being researched. We had also done a lot of work, but unfortunately unsuccessfully on the heart using stem cells. Tissue engineering is happening, and in time people are going to be able to, this has also been done successfully, like creating a rat's heart over a scaffold. They grow myocardial cells over scaffolds and they can create new organs. In fact, there was a travelers, there is a series called Travelers, you should try and see that. They were using something called nanites that are injected into the bloodstream, and they can regrow organs. So some technologies like this will come in time where we will be able to grow organs in petri dishes, and surgeons can go in and replace them from the diseased organ. So genetic engineering or 3D printing of organs is something that is really coming in time. Also, we will get better ventricular assist devices, and it may happen that anticoagulation is not required. These devices will be superb. And so if there is a problem, we'll just go in and put a new device. No angioplasty, no bypass, no valve replacement. Just get, this is a Jarvik device, and this is a Novak or left atrial assist system. So these devices are also available now, and they can be used, in future, they may become more frequently used things. Just open the thorax, put a Jarvik, connect it to descending thoracic aorta, and all is well. So such technologies will get better. We will get total artificial mechanical heart, and this is what they will look like. So I'm not sure how many of you saw Robocop, but in Robocop 1, they showed Yamaha 10,000 as a heart. Sorry, I have not done the drawing on the slide. So
No,
something like Yamaha 1,000 or 10,000 they show in Robocop 1. So we will get excellent artificial hearts with good engineering going on. And in future, maybe all that will be done is surgeons will go in, chop off the old organ, put a new organ. So things can happen. Well, as doctors, our aim is to make lives of our patients more comfortable. They can live more happier times with their families. They can spend more purposeful or meaningful lives rather than being stuck to the beds. And cardiac surgery has really achieved this goal. It has really changed lives for thousands and thousands and millions of patients who are stuck to the confines of beds, and we've been able to move them around. Cardiac surgery, I do not know what the real future will be, but at present also, it is amazing. It gives such lovely answers to such impossible problems, and it is a very happy place to be in. Frequently, I thought of becoming a neurosurgeon, a cardiac surgeon, or a neurosurgeon or an oncosurgeon. And I thought, okay, would my life be about chopping organs? Would my life be about having handicapped patients? I was a coward. I wasn't brave enough to become a neurosurgeon or a cardiac or a cancer surgeon. So I thought, let me take the easy way out. Let me become a cardiac surgeon. And when I was in seventh grade, I read a story somewhere about Christian Bernard changing the valves of a child. And though the child had not survived in that particular story, that story moved me so much that right from seventh grade, I had only one aim, to become a cardiac surgeon. So it's a lovely branch. A lot can be done. It's amazing the reaches. And honestly, having a beating heart under your hands gives you thrills every single day you're in the operating room. So this is about
Excuse me,
cardiac
sir.
surgery.
I'm really
Thank you
sorry
very
to
much,
interrupt you.
everybody, for listening to me very patiently for over an hour. Thank you so much. Over to you,
Can the
Anil.
host please stop the annotation?
uh, thank you so much for that doubt. We're just working on that. There are some technical issues which we're facing. We'll just correct
Can
that.
you speak a
Thank you so much.
little loudly, Mauli? I can't hear you.
Yeah, absolutely. Just thank you so much for that doubt. We're very sorry for the annotations happening. We're facing some technical issues because of which we're not able to stop it. But just a minute. Uh, just yes. All right. Thank you so much. Thank you so much, sir, for for such an informative presentation and for clearing so many doubts regarding cardiac surgery all the students had. We received a lot of doubts, in like during the webinar about what is your journey as a cardiac surgeon and what motivated you to go into this field, and how has it been for you in the past 20 to 25 years, where you've almost seen more than 40,000 hearts, 40,000 beating hearts. And what has your journey been like, sir?
Well, as a child, I was always, in awe of cardiac surgery. I don't know why. Seventh standard, like I said, I read this in Reader Digest. There was a story about a surgeon, he was scrubbing up for a cardiac surgery. And that was 1976. Can you imagine? 76. I was in seventh grade, and this story in Reader Digest I read. The surgeon is going towards surgery, and he says, this child, he needs two valves to be replaced, and I'll replace him. He'll become okay. And I'm like God, I can do anything. And that surgeon has so much ego about himself. So he was heading toward this operating room when he saw this child being wheeled into the theater. And the child just asked him, can I have a piece of bread? So the surgeon says, well, you're nil by mouth. You have to go to the theater. So you can't have bread right now. But once your surgery is done, you're all right. You can eat and play and do whatever you want to do. And then he goes to scrub. He does the operation. The child comes out of theater. Next day, there's a problem. He takes him back to the theater, does something, brings him out, and ultimately the child dies. So then the surgeon says, okay, well, I thought I was God, but I could not give the child even a piece of bread. It was such a touching story to a boy in seventh grade that that boy decided to become a cardiac surgeon, and here I am today. So seventh grade until date, that is how I became a cardiac surgeon. Throughout my life, then after that day, I had dedicated and decided I'll become a cardiac surgeon. Life was difficult. The time I started doing cardiac surgery in 1989, I met Dr. V.C. Patel, and for the first time, we started cardiac surgery in Gujarat in 89. And that time, Dr. Girinath and Dr. Parulkar and Dr. K.N. Dastoor had come from all over the country. And we did around 25 surgeries in 25 days. And it was an amazing experience. And I was in so much awe of cardiac surgery. I said, okay, this is my branch. And when I finished my general surgery, I was in general surgery training at that time in 89, when first time cardiac surgery started in Gujarat. And when I finished that in 1990, 91, then I went straight to Chennai and I met Dr. Girinath and I said that I want to do cardiac surgery with you. And I joined him. And when I was in Chennai, that time in 91, we used to visit Gujarat to do cardiac surgery. And we started the first cardiac surgery programs in 91 in Civil Hospital, Gujarat. After that, I went back to Chennai. I finished my training, and in 93, I came back to Gujarat, and I had this aim. Though I was only 29 years at that time, I had this aim that I will be the pioneer of cardiac surgery in Gujarat. And in 93, when I came back, there was no place for a cardiac surgeon. Nobody wanted a cardiac surgeon. Nobody gave me a job. When I joined a hospital, Mayo Hospital, saying that I'll start cardiac surgery. So we started the first cardiac surgery program in Mayo Hospital, in private sector and corporate in 93 in Gujarat. Can you imagine 93, way back? Many of you would not have even been out of your diapers at that time, if you were maybe not even born at that time. So then I went into cardiac surgery at that time, and we did the first few private surgeries in Mayo. After that, somehow it didn't work out there. I came to Ahmedabad, and from there I developed cardiac surgery in Gujarat. It's been a very, very rough journey. The first patient I took in for a bypass surgery, the nurse outside the ward said, this is gone, he will die. This was what was believed, anyone heading for cardiac surgery will die. And well, that patient survived, many more survived. And that's why we are here at, 35,000 surgeries. And your father has been witness to most of this journey, right from 93. He and me have worked together so many long years. That's been the journey. It's cardiac surgery is, like, it's not because I'm a cardiac surgeon, but it's a very thrilling profession. See, it doesn't give you rest. It doesn't give you time to sit at home and think. It doesn't give you a good family life, but it gives you a satisfaction. You've done something amazing. I know becoming an ophthalmic surgeon or becoming a urologist is easier. You don't have emergencies, you don't have problems. But if you need the kick, if you want the thrill, you want to do something in life. And I believe all of you are young students and you should do something, be something, get somewhere. It's not supposed to be only just earning money or something like that. Not for money's sake, but for the thrill's sake, you should take cardiac surgery. And let me tell you, students, something. Nowadays, there is a shortage of cardiac surgery. People do not go to cardiac surgery. Seats every year go empty. Nobody is ready for a difficult life. But honestly, like Robert Frost said, two roads lead into the jungle. One was well worn out, one was not used. I took the one less taken, and that made the difference. So I think people should take a different path. You must not take the worn out path. Take the different path. It will make a difference to all of you children who are listening or students who are listening to me. So try to do something different. Try to do something big. It should not be just being a doctor, but being something is important. So I think cardiac surgery is, and for me, this poem is true. Two roads that led into the jungle. I took the less trod one, and that made the difference to me.
Thank you, sir. That was very, very motivating for all of us. And I'm sure that in the audience, we have hundreds of medical students right now thinking about cardiac surgery, how to go about it. And as you mentioned, that cardiac surgery is one of the most hectic and on, like you constantly have to be aware and alert regarding any situation that might arise. So, what does a day, being a cardiac surgeon look like for you? How do you, how do we have a lot of questions, regarding how do you handle so much stress, and so many years you've been doing so. We're sure that it's not at all an easy job um to go through so many years and handle so much stress with, with so many emergencies along the way. So how has that been for you?
See, cardiac surgery needs a lot of dedication. You do not have many opportunities. You have to sacrifice a lot of your family time. So, number one, yes, it is stressful on you and your family. And many times your family is not happy about you not being around. So, whenever there is a party, that's very typical. You have an evening, you have a function, you have a party, and last minute, when the party starts, you get a call that there's an emergency. So this is the best way to try to miss all the parties. So if somebody is not a party animal, do cardiac surgery. So you'll get to miss all the parties at home. Second, your partner. If it's a female, for her, it's her husband. If it's a lady, a male doctor, it's her wife. Both have to be very supportive. You cannot do cardiac surgery without a supportive partner in life. So you need a supportive partner. Yes. Emergencies and stress is awesome. It is awesome means, you it's when you're in the most difficult times, you need to be the coolest. And I think the difference is your team. If you want to be a good cardiac surgeon and you want to handle stress better, in fact, in medicine, I believe that you have to develop a team of people around you. You have to a good anesthetist around you. You have a good support staff around you. You have a good, even all of you as doctors, as you go forward in life, remember, build a good team, whatever branch you take, whether it is cardiac surgery or gynec surgery, or you're a physician or you're an intensivist. The most important is a good team of people who will be there in the time of crisis. So, though you are the treating physician or treating consultant, but if you have good people around you who are intelligent, who can keep their head on the shoulders when they are in trouble, these are the people that make a difference. And that is how you handle stress. 50% stress or most of your stress can be taken by your team if it's good. And other thing that's very important in this profession is be well consented with your patients. Whenever you take a patient up for surgery, take proper consents, counsel the patients nicely. So what happens if some complication happens, you've told them about it. So you are not as worried. Stress is more handleable. If, for example, your patient has not been counseled properly and he doesn't know anything, he doesn't know that he can die out of this operation, then if the patient dies, the relatives will make your life miserable. So the two ways of reducing stress is, one, of course, you have to be good at what you do. No doubt about it. You can't be messing around. Second, is good and be well trained. So that's very important. Good training is so important. So if you're well trained, you can handle stress better. Second, have a good team around you. And third, have proper patient consenting. And fourth, see that your paramedical teams are excellent. So that makes the difference. So that is the best way to handle stress. And of course, either you should have a wife or a husband who understands. You can't be in the hospital 20 hours out of 24 hours without an understanding husband or a wife. and
Thank
children who will not want you to be there on the birthday.
Thank you so much, sir. Thank you so much for that answer and for clarifying that. Uh, Again, one of the questions which we've received from one of our participants is that what kind of surgery do you face most commonly, and what are the type of what is that division of cardiac surgery which leads to mortality in in so many years of the surgeries which you've seen. Uh,
Yes.
yes.
See, the most common surgery nowadays performed is coronary artery bypass surgery because I'm an adult cardiac surgeon. If it's a pediatric cardiac surgeon, most commonly you'll see a VSD. So for adult cardiac surgery, most commonly performed is a bypass surgery. These are very common and everyday in and out common bread butter surgery as a surgeon calls it. Other than that, there's a lot of valvular. Mitral valve disease is pretty common. Mitral valve repairs are plenty in number. And less than that are the ASDs and atrial septal defects because nowadays a lot of them are closed percutaneously by cardiologists. So most popular are CABGs, valvular heart disease, and in congenital you get VSDs and tetralogies. These are very common. Mortalities are common in patients who have sick hearts. So, you can have people who have a 60% ejection fraction, which is normal. So they usually do well, but patients who either come in emergencies with a bad heart, like less than 25% ejection fraction, or patients who have severe pulmonary hypertension or right ventricular dysfunction. These are the ones that can give trouble. So they are the ones that have mortality. But a standard run-of-the-mill coronary bypass surgery has a 99% survival rate, and that's a very common operation.
Mhm. Thank you so much for that information, sir. And so also, in a lot of us are medical students right now, undergrad medical students. And what will your message to all the students out there be? Because as of now, for speaking from my personal experience, at this point, I'm at a crossroads whether to take medicine or surgery. So there are so many students, who are I'm sure be who might be in this confusion. And what would your message to all the aspiring cardiac surgeons out there be? I'm sure from such a overwhelming audience, I'm sure there will be many students who would be interested and who would be willing to go in the direction of cardiac surgery. And the guidance and the directions which we receive from such experienced cardiac surgeons like you makes a lot of difference. So what do you think that can be done differently in cases of undergrad medical students? How can they go closer to their goal? How can they explore more in to go into this direction?
Yeah, I've been to Disneyland many times. I have visited most of the Disneylands in the world. And, I see those big roller coasters. And the minute I see those roller coasters, I start feeling dizzy, that I could puke, that I could vomit. So I don't have risk taking capacity in terms of going on to big roller coasters. But see, everybody has the risk taking capacity. But in life, I said that I can't be a surgeon. I can't be a physician. I can't just be going around with a stethoscope and writing medicines. I want to do something more different. So if you want to do something different with your lives, like, something active, if you want to really go in and do something physically, then surgery is good. And honestly, not because I'm a surgeon, but I think being surgeon is a wonderful experience in life. It's I have lived my life in surgery. Every day of my life I've operated, and I've done thousands and thousands of surgeries, and I've seen millions of liters of blood in my life. So if you don't mind seeing some blood, if you enjoy cutting up and stitching up people, in this world, only surgeons have this right to cut someone. Do you think anybody else can cut someone and get paid for it? It's called murder if you try to cut someone. But surgeons, they are, by the virtue of their degree, their learning, their education, they can do surgery, and surgery to heal. It's an amazing thing. It's the final solution, the final, judgment for many people who live around in this world. So it's surgery for those who even are inclining towards surgery. I tell you, take it. It's an amazing thing. You will never regret doing surgery in life. But you should be able to handle the blood. You should be able to handle the hours. And though it is fun, it has its challenges. So surgery is a good thing. So to do cardiac surgery after, of course, I recommend more frequently than not to do general surgery. Go around in rotation, like spend few months in cancer surgery, few months in cardiac surgery, few months in neurosurgery, or whatever branches you want to do. Spend a few months in various hospitals, and then, or maybe in your own hospital in rotation, and then you take a decision what you want to do. I don't think the 6-year course is a good idea, but if someone is surely decided, he can do a 6-year course and do cardiac surgery. So, go around, have a look at everything. Our hospital is open. If anybody wants to come, they can come to our hospital, it's Epic Hospital in Ahmedabad, and we do around 7 to 8 surgeries a day. So you just welcome any time to come and see cardiac surgery at our institute. So that is a welcome invitation. So go see it, experience it, and then decide what you want to do. Not just because you want to make money, but that should be what you want to do in life. So that is a good way to take a decision. And you need to give the NEET and NEET. Nowadays, last year, they reduced the NEET bar required for cardiac surgery because nobody was taking cardiac surgery. Now, even if you pass the NEET, you get into cardiac surgery or minimum marks you can get. So cardiac surgery is easy to get.
Thank you so much for such a vivid explanation, about cardiac surgery and the advantages to take it. We so one of the interesting questions which we have in our chat is also the prospects of cardiac surgery in India and in abroad, because currently we have so many students, who are looking at many different options in India and abroad. So how do you think the prospects differ in both the situations?
Well, honestly, nowadays, there is always this challenge. People feel, yeah, will I get something to do as a doctor after I graduate or after I pass out? Will I get some work for myself? Well, there is a level of saturation in a lot of specialities nowadays. Like if you say there are orthopedic surgeons around, there are general surgeons around, GI surgeons, of course, are in biggest trouble. There are so many GI surgeons. So compared to all of that, there's a lot of saturation in a lot of fields. There is much less saturation in cardiac surgery. Still, cardiac surgery, the challenge is from the cardiologist. More and more things are becoming minimally invasive or non-invasive or percutaneous. So yes, there is a level of challenge in cardiac surgery in the way that cardiologists have taken over a lot of work. But given the Indian population, that we have such a huge population of diabetics, such a huge aging population. Do you know 130, 140 crore people and how much cardiac surgery is done per year in India? Only 3 to 4 lakh cardiac surgeries are done. What is the requirement of cardiac surgery? At least 30 to 40 lakhs is the minimum. Even if you throw away figure, it would be 30, 40 lakhs. If you're really trying to treat people with cardiac surgery, then it would be 30, 40 lakhs. In India, we do not have the surgeons, the staff, or the people to do that number of surgery that we need. So if really we want to treat people in the country, if people are supposed to get treated with cardiac ailments, then 30, 40 lakh cardiac surgery is normal. I think as time is going to come when people are going to wait outside the offices of cardiac surgeons for their turn to get operated. And even today they wait outside our offices for turn to get operated. There is so much work. And well, internationally, yes. Around the world, less and less surgeons are being generated. Like America is falling short of cardiac surgeons right now. And in future, they will get even more short. So I do personally believe that, yes, internationally also, if you want to go, if you want to travel, go out. If you're a good cardiac surgeon, job opportunities are not going to be a problem anywhere in the world.
Thank you so much, sir. I'm sure that must have answered a lot of the students' questions. And also, one of the I'm sure that one of the very common experiences you would feel, as you also already mentioned before also, is with the patient's relatives. And cardiac surgery, I'm sure, is like it's a lot. It's, as you already mentioned, it's very stressful in terms of, like, in terms of emergencies and everything. So how do you manage to handle unpleasant situations with patients and with relatives? I'm sure that would be a skill which you've acquired along the years. So
See, like I just said, okay, what is very important is consenting. Right from the moment go, the patient walks in the office for the first time, you have to start talking to them. Okay, this is your operation, this is what you need, and this is the problems that can happen. If they are well consented, 50% of the job is done. But after that, also being honest to your patient is very important. If something goes wrong during surgery, you have to come and tell him that this was the problem, this is a known complication, this happened. So as long as you're honest with them, you don't hide anything from them, and you have a compassionate approach towards a complication or compassionate approach towards relative in in difficult times, then there are no problems. But if you get egoistic, if you think I'm too big to go and talk to people, if you think that oh this can happen and it's okay, then that is the time you get into trouble. So being compassionate with relatives, properly consenting them, telling them that these are things that can happen, that is what actually helps prevent difficult situations. So don't ever think okay, you are God. Don't ever think you're above everything. Be normal, be nice to them, and nothing goes wrong. Talk to them all the time. Keep talking. Today also, at this stage of my life, if there is a complication, I go to the hospital. I'm there before anybody else gets there, and I'm talking with the relatives. So that makes a difference. Don't hide things and don't run away. Be there. Don't run away. If you run away, surely they're going to come running after you. You're in trouble. They will run after you.
Thank you so much. And I feel that is something which all the medical students need to incorporate to a very great extent in their lives ahead. And I think we can take one last question. And one of the questions which a participant has asked is that can you say, like, can you please explain that why is it that there are lesser cardiac surgeons, nowadays? What is, what do you think is the reason behind the decreasing number, which is, which we are witnessing right now?
Well, in this modern age of 2020, with a lot of stuff on Netflix and Amazon Prime, I don't think anybody wants to spend time in the operating rooms. It's better to enjoy Amazon and Netflix, do some chilling surgery like prostate or something that can be cataract. I was talking to someone. I'll give an example why. I know someone in Mumbai whose mother got operated for cataract in both the eyes, and they went to the cataract surgeon and he did the cataract. It took 12 minutes to remove the cataract, and total stay in the hospital was 2.5 hours. And the surgeon was paid 50,000 for the cataract, and the lens cost 25,000. So 75,000 for a cataract, and the next eye is still pending. So another 75 for the other eye. So imagine 1,50,000 for 24 minutes of surgery.
Oh,
So who
okay.
would not want to do that? Who would want to do cardiac surgery where you're hardly paid that much less than half of that amount for doing cardiac surgery? So it's not it's not rewarding enough in terms of finances, in terms of money. It's rewarding in terms of a profession, but it's not that rewarding financially. And hence people shy away from difficult branches. More than that, emergencies, chances of complications, and the learning curve, the time it takes you to become a good cardiac surgeon. Today you have to do general surgery, then you do cardiac surgery, and then you spend a few more years learning how to do it. So it takes you nearly 30, 35 years before you can even, say 35 years when you start really working as a cardiac surgeon. So who would want to spend 35 of the years of your life doing this? But the thrill, the fun, and being there is important. So I think that is the reason why people don't take it. It's you want the easy way out, but honestly there is fun. It's an excellent branch and the results are superb. And with the way technology is improved, there are lesser emergencies now. For example, previously if there was an emergency at night, we'd have to go and operate at night. But now we've got something called balloon pump and good medicines, good anesthesia. So we don't have to run that much. We have a busier practice, less emergencies, more stable work. So now it has become like a 9 to 5 job. So things have changed. People don't know things have changed. Students don't know things have changed. Things have changed in cardiac surgery. Emergencies have come down, stress levels have come down, techniques are refined. If you do a particular operation in a particular way, it is predictable. You know okay, this is how it is going to be. So if you're well trained, good equipment, good instruments, good hospitals, it's fun to work, do a 9 to 5 job and be a cardiac surgeon. I think times will change and more people will take cardiac surgery now. It will change.
Thank you so much, sir. I feel that's a beautiful note to finally end our
Yeah, things
today's
will change.
session on cardiac surgery. I'm sure that through today's session, a lot of students would have been motivated, and I'm sure they would have gained a lot of clarity as to how to go ahead, as to what it looks like in a more vivid and clear way. So thank you so much again for agreeing to do this webinar.
Only you can, if people want, you can let people have my number. They can message me and I'll reply them on WhatsApp. Yeah,
Sure,
I can put my number. You have my number. I'd
sure.
love to help students. And if somebody really wants any help, wants to dream of being a cardiac surgeon, they're welcome to get in touch with me.
Sure,
Okay,
sir. I'll
that's not a problem, and it'll be a pleasure. Even if I could have, this lecture could have, stimulated 2 people to become a cardiac surgeon in their lives. That's enough. I want to change something in this world. Get more people to take up this branch. So
Thank
that'll
you
be
so
lovely.
much. Thank you so much. I'm sure that, like, just hearing that, just hearing those last two lines would have motivated a lot of students to gear up and work twice as hard as they twice as hard they do to work towards that goal.
Yeah.
I'm putting down sir's number in the chat box. So if anybody has any questions later, or if anybody wants to ask something which maybe we couldn't address in the webinar due to the time crunch, please feel free to do so. And thank you so much again. Thank you so
Thank
much
you.
again for taking the time
Thank you,
out.
Molly.
And thank you so much to all the participants to be patient, to to be patient with us and to ask so such nice questions. And that with that we shall wrap up today's webinar, the first session on Decode the Specialty. And thank you so much again.
Congratulations, Molly, on organizing such a lovely event. Thank you.
Thank you.
Thank you, everyone, for being part of it. Thank you so much.
Thank you, sir.